Okay, the next installment in the medical student ultrasound curriculum is the musculoskeletal section, and this can be incredibly difficult when you first start doing it, but in the end, I think you'll find that it's actually really intuitive and really lends itself to being useful in a multitude of ways for lots of different specialties. And it took me a while to kind of get comfortable with it. And I have to admit, there were a lot of people on the way that helped me with this. Dr. Bouffard is a PM&R and radiologist at Wayne State in Detroit. And he and I have done some teaching together in the Philippines and at various conferences. But I'll tell you, he's really I would say, the world's expert on musculoskeletal ultrasound. And if anybody's interested in hooking up with him for a summer research thing or whatever, let me know. And if that's something you want to push to the next level, that's the guy to go to. Locally, we have Dr. Cruz, who did family medicine and then a sports medicine fellowship, and he's been a lot of help in teaching, and you guys will likely meet him this week when you're doing your hands-on sessions. And then Ben Dubois is an orthopedic surgeon out of San Diego who basically taught me a great hands-on course on the shoulder. He's sort of a shoulder expert down in San Diego. Again, local guy if you're interested. And then Alan Chim has really run with the shoulder, so to speak. And he's my current ultrasound fellow who did the majority of the videos that you're going to see here. In fact, all the videos that you're about to see here in this talk. And many thanks to him for all the hours he put into this lecture. And then Stacy and Tim. Stacy and Tim were both volunteered to be the ultrasound models when we did the videos, so thanks to them as well. Now, we're going to talk about three areas: the shoulder, the knee, and the wrist, or the hand. And we're not going to go through any pathology. This is an anatomically based lecture. You got to get the anatomy down first before you start moving on to the good stuff. But there is a lot of good stuff that you can do with ultrasound. And a lot of it actually, believe it or not, is as good as, or in some cases even better than MRI. And so that's what makes it so attractive. Now, you can see fractures, dislocations, or even subluxations, osteochondromatosis, bursitis, and all the various joints, particularly in the shoulder, rotator cuff tears, tendinosis, impingement, ruptures of the tendon, or partial ruptures or unstable tendons, paralabral cysts you can see, adhesive capsulitis, and also ultrasound is really good for doing guidance, injections, and aspirations. Now in the knee, we can see tendinosis of the quadriceps muscle, tears of the tendon and the muscle. We can see a tear of the patellar tendon, patellar tendinitis, fluid collections in all the joints, but in particular, it's very common to see this in the knee. You can see the pannus and rheumatoid arthritis, patellar bursitis, tears of the MCL. We're going to spend some time on the MCL. It's very, very easy to see. And something called a Baker's cyst. And finally, in the wrist, all kinds of, again, joint effusions, synovitis, rheumatoid arthritis with bony erosions, and differentiating that from psoriatic arthritis, de Quervain's, tenosynovitis, tendon tears of the wrist and the fingers, carpal tunnel syndrome, gamekeeper's thumb, scaphoid fractures, and then ganglion cysts and other masses. Now, the transducers that you want to really focus on, particularly the ones that we have access to all over the place, so the linear transducer. Remember the linear probe, high frequency, best resolution. If I was stuck on a desert island and I can only bring one transducer with me, then this is the one I'd bring. The images are beautiful. Whenever I can get away with linear probe, I'll use it. Now there's also a hockey stick probe, which tend to have even higher frequencies, and there's an example of one down here. You can see how it's a little bit easier to manipulate in small areas, like the hand and the wrist and stuff like that. So we do have one of these in the emergency department, but it's not that common of a transducer. The linears are everywhere. And then sometimes you're so close to the thing that you want to see that you have to actually stand back a little bit in order to get the optimal focal point, and that's why we have these standoff pads. They're gelatinous pads that you can reuse. And if you don't have one of those, you can just dunk the part in a water bucket. I've done a lot of that with the hands and the feet over the years. But if it's something else around the shoulder maybe that's hard to dunk in a water bucket, you could use a standoff pad. Even take a glove, fill it up with ultrasound gel, and you have an immediate standoff pad. And for the most part, we're going to be in 2D mode, though some of the pathology will require power Dopplers to look for inflammation. Now, there's many benefits to using ultrasound. Obviously, we've talked about these before. I'll just brush through this. You can use it basically anywhere. And the major advantage it has over the other three imaging modalities, of course, is that it's real time. You're seeing tendons move in real time. You're seeing actual functionality of the structures. And that's a huge benefit with ultrasound. And in particular with musculoskeletal, sometimes there's a bit of a learning curve here, but you always have the other side to compare to when you're worried about something pathologic related. And so if you're not sure if you see a tendon tear or not, or it's a partial tendon tear, go look at the other side, assuming the patient hasn't had an amputation, and you should be able to compare it. And that's really helpful. Of course, there's no radiation exposure, and it's safe. Now, limitations are really making you comfortable, and that's why we integrate ultrasound into the 4 years of the medical school here, so that by the end of medical school, you feel like ultrasound is this natural extension of what you do. It's just sort of part and parcel. You feel confident behind it, and that requires experience because it can be quite operator dependent. And you can imagine, learning this like I did after residency required a lot, sort of more hours and work put into it versus if I had it trickled in over the course of medical school and residency, it would have been, much easier. I would have been much more confident right from the get-go. That being said, it's not that hard to learn, actually. It just requires a little bit of commitment. Now, let's get into this here. There's soft and hard tissue that we can see. Most of the tissue is soft. It extends from the skin line, seen up here, and down through the hypodermis, also called the subcutaneous tissue. And then there's this subcutaneous fascia seen here. That's that hyperechoic line. And then below that, we can see, muscle. And then finally, there's bone. And the bone is the hard tissue. It's very dense. It strongly reflects the sound. And thus, it creates a very hyperechoic cortex landmark here. Now, tendons are themselves should be readily identifiable on the ultrasound. Because tendons are so dense, they appear quite hyperechoic and certainly much more hyperechoic than muscle. They have a fibrillar pattern and they should be completely visualized as a musculotendinous unit. In some ways, it's a joint between the muscle and the tendon, that area where the muscle and the tendon joins together. Some people call that a joint. It's you can see that musculotendinous unit throughout its complete range of motion. Now, if a tendon defect is visualized during this dynamic evaluation, a tendon injury really should be suspected. And there's another concept called anisotropy that you see many times with tendons, and I'm going to try to explain it here. Now, anisotropy, it's basically tissues that exhibit ultrasound properties that differ according to the direction of the ultrasound imaging. In other words, with muscles and particularly tendons, depending on which angle you insonate them, they can display variable echogenicity. Now, as this video illustrates, the arrow, which I don't have, but this arrow here, this arrow points to the tendon as it's coming along here, and then suddenly there's this sort of drop-off, right there. And so the tendon comes along, and then there's a drop-off. Does that mean there's been a tendon rupture, or is this just false hypoechogenicity from an obliquely angled ultrasound beam? And that's exactly what happened here. As the tendon was trying to come across this bone here, the ultrasound hit it at a different angle. And then once we correct the angle, we can see the rest of that tendon again. So just be careful with that concept of anisotropy. False hypoechogenicity from an obliquely angled ultrasound beam. See it with tendons mostly. And here's a tendon taken through its range of motion here. As the joint gets ranged, we can see this tendon demonstrate a homogeneous and quite hyperechoic appearance. as it slides along its tissue plane. Now, muscle is hypoechoic, relatively speaking, and one can see the muscle itself with the overall it's hypoechoic, but we can see the hyperechoic striae seen here in this fibrillar pattern. So if you line up that linear transducer in the long axis of the muscle, you can see these linear fibrillar striae going across, and in between the different muscle bundles is a multi-pennant, it comes across in this multi-pennant fashion here. And so this is sort of one muscle bundle over here, and this is another muscle bundle down here. And we can see some hyperechoic connective tissue here at the top of the screen. And so you're sort of differentiating these different tissue types as you go through musculoskeletal ultrasound. We flip that same transducer on that same muscle into the short axis view, and now that what was stretching out across the screen, that long fibrillar patterns, now look more punctate as opposed to the linear fibrillar pattern when you're in the short axis looking at muscle. The bone too, now down here, is instead of stretching out across the screen, is seen here in its kind of a radial pattern, very dense and echogenic. And it depends where you insonate the muscle. It will really change as you sort of fan down through its course. And so this is looking posteriorly in the back of the calf, and we can see the gastroc is very superficial and soleus is deep to it down here. Now as I move down through these still images, we're going to go a little more distal here, and as I go distally, we can see the gastroc kind of starts to go away. The soleus remains pretty prominent. Now we can start to see the tibia down here more medially, and then we can see two bellies here of the gastroc. The soleus is down here, and when I use the real-time clip to fan through it, again the gastroc gets very thinned out, soleus takes over as we go distally. Now we're going more proximally, gastroc gets bigger, the two bellies of it there, gastroc, soleus down here. Really make out those two completely separate muscles here quite easily on ultrasound. Now, what about the joints? A lot of people call this the seagull sign. When you've got one bone coming up to another bone, you can see the sort of the soft bony ends coming together. See this? So this is actually the metacarpal bone here, and this is the proximal first phalanx right here. And where those two things come together, we can see this is that joint space in between the two. And then this phalanx goes along, and then there's another one out here. And so when we're making out these joint spaces, you're really, it's a potential space, and unless there's really fluid there, it's hard to see sometimes exactly where the bony ends start and stop. But it is an articular place where they come together, and we can see in this case their ends as they approach one another. In this case, this patient does not have any fluid in the joint space. If there was fluid there, it would be pretty obvious and anechoic. And because bones are so easy to see on ultrasound, fractures are very simple, actually. And I know I'm focusing on anatomy, not pathology, but I mean, you can really see these step-offs quite easily with fractures, actually. And the nice thing is you basically hand the transducer to the patient, say, put it where it hurts, and then you'll see the step-off. But this is what intact cortex looks like. We can see that hyperechoic line coming along here. We see this hyperechoic line here, joint space. We can see this hyperechoic line coming along here. And in these cases, either muscle or in this case tendon will be superior to the bone, or I should say superficial to the bone. And again, these fractures, these cortical fractures, super easy to see. I mean, boom, big step off. And a lot of times you'll get this hematoma formation in between the two bony ends. Here's a clavicle, boom, big step off. Other part of it's down here. Again, hematoma formation. And this is a much smaller step off here. But we can see fractures all over the body with ultrasound, from the skull to the sternum, places that sometimes it's difficult to pick up with an x-ray. And ultrasound will pick it up. Scaphoid fractures, all that. Now, we're going to talk now specifically about the shoulder, and this is probably the most commonly performed musculoskeletal application of ultrasound, and in terms of the indications to perform musculoskeletal ultrasound, shoulder is at the top. And so I think it's worthwhile kind of focusing on some of the anatomy here. And I'm not going to do an exhaustive anatomical overview. I know you guys are doing that anatomy. I'm going to really focus on the ultrasound stuff with the biceps subscapularis, the supraspinatus, and the glenohumeral joint. Now, the biceps tendon is seen in the bicipital groove, and so what you're looking for is this structure right here. Here's the short axis of the head of the humerus, so we can see this is the area there. Now we know why they call it the bicipital groove. The biceps tendon fits actually quite nicely, and this is the short axis here, and then this is the long axis down here. And you're really looking for that echogenic oval structure that's in that bicipital groove. It enters deep to the transverse humeral ligament, and the fibers can be seen to extend into the subscapularis tendon that's essentially located between the greater and lesser tuberosity and deep to the deltoid. Pec major tendon stabilizes this area at the level of the myotendinous junction, and in the longitudinal plane we can appreciate these fibrillar patterns seen here. Alan, show us how to find the biceps tendon.
The structure that I'm interested in is the biceps tendon in the bicipital groove. And I'll put the probe actually in a transverse orientation with the indicator pointed to the patient's right, or actually laterally, depending on what shoulder it is. So what I first identify on the ultrasound image is essentially the greater tuberosity on this side right here, and then the lesser tuberosity on right here. And in the middle, you have this anechoic structure, but if you notice, if I just fan this way, it becomes very bright, and that's the biceps tendon in the bicipital groove. A long axis view of the biceps tendon. I'm going to start from the short axis and actually hold the probe and actually put a finger on the patient's skin so that I know that the probe isn't going to move anywhere. And I'm essentially just going to rotate 90 degrees with the indicator point towards the patient's head. And when I do this is actually a view of the biceps tendon on the long axis. I'm trying to get it right here. Here we are. So what I'm going to do is I'm just going to follow it down. So your biceps tendon should look very fibrillar, very linear, and a little hyperechoic as well. And essentially I'm going to go until I hit the pectoralis ligament, which is about right here. This is the pectoralis ligament right here. So if there's actually any fluid, what we'll see is that there will be an anechoic surrounding or cavity around the biceps tendon, or if there's actually a partial tear or a full tear, we'll see that the fibrillar pattern disappears.
Now, the subscapularis is a multi-pennant structure that arises anterior along the anterior aspect of the scapula. It inserts on the lesser tuberosity, and if you can see, there's some bursa there. It's just sort of anterior to the tendon, and when you externally rotate the arm, therefore, you can make out this area a little bit better. Once again, Dr. Alan Chin.
So in order to get an image of the subscapularis, remember that the subscap actually attaches on your lesser tuberosity, which is medial. So when I actually identify the lesser tuberosity up here, I'm going to have the patient slowly externally rotate. And when the patient externally rotates, you get the actual subscap in the long axis view right here. And remember that my probe is actually still in the transverse orientation. If I want to get a picture of the subscap in the short axis view, I'll rotate my probe 90 degrees, and what I get is essentially the subscap in the short axis view with the humeral head, some of the articular cartilage right here, and then the subscap up on top right here.
So that was kind of weird. It confuses me sometimes. Like, wait, the probe is transverse, but the subscapularis is longitudinal. How does that work? Well, if you think about it, here we have the probe in a transverse plane like this, but the muscles are running in a longitudinal fashion underneath the transverse probe. I'll say that again. The muscles are running in a longitudinal fashion underneath the transverse probe, which is why we see it in a longitudinal plane, the subscapularis that is, when the probe is placed along the body's transverse axis. And the opposite's true. So if the probe is in a longitudinal axis, well, we're going to see these, the contour of these dot-like formation here of that subscapularis when it's in its transverse plane. Now, what about the supraspinatus? Remember, that's the one that rides right up here on top of the scapula. So therefore, if you have the patient, internally rotate their arm and sort of flex forward, and you put the probe like right on top of it, then you're going to see this supraspinatus tendon coming across here in its longitudinal plane because it's running in this fashion here. And we'll have Dr. Allen explain it even better.
So in order to get the supraspinatus tendon at its insertion point at the greater tuberosity of the humeral head, what I have to do is actually have to have the patient internally rotate and also essentially extend his shoulders so that the supraspinatus tendon drops into the anterior view. And this is what I see actually on ultrasound. Essentially the supraspinatus tendon attaches right here at the greater tuberosity, and this is also known as the critical zone because the vascular supply is not as good as at other points at the tendon insertion. So this is actually where you'll see a lot of pathology.
And then in the transverse view of the supraspinatus tendon, basically you're looking for where it inserts on that anterior facet of the greater tuberosity. And the normal thickness of the structure is about 6 millimeters. And it's the same on both sides, whether it's the dominant side or the non-dominant side. Now, a lot of people say that this structure running across like this kind of looks like a bird's beak. I don't know if you can appreciate that or not. Sort of the way like a bird's beak would come across. I don't know, maybe a little bit. But we'll, when you break down the exact specific anatomy, you can see this here. This is the superficial area, then where the skin is, and then the subcutaneous fat, and finally we get down to that deltoid muscle. The superficial muscle that you see is the deltoid muscle. Then you get down a little bit deeper, we can actually make out this bursa. Really, this is a very thin hypoechoic sliver right here, and then deep to that is the supraspinatus tendon, that bird's beak structure. Deep to that is cartilage, and then bone seen right here with its characteristic shadowing. Alan's going to describe how to find the transverse.
So from the long axis of the supraspinatus, all you have to do is just rotate the probe 90 degrees. So more perpendicular and point pretty much upwards towards the ceiling. And what you get is the supraspinatus in short axis view. You have the humeral head, you have the articular cartilage in between the supraspinatus and the humeral head, and you have the subacromial bursa that's right on top.
Perfect. Okay, now we're going to take the probe and put it on the back of the shoulder. And when we put it on the posterior shoulder, what we see here is quite well is this, the glenoid of the scapula, how it interacts with the humerus. We call that the glenohumeral joint. And in between the two is this posterior labrum. It's this triangular shaped structure here. And yeah, we can see infraspinatus coming across here, just on top of the glenoid. But I want you to think about the anatomy, how you'd put the probe on the back of the shoulder. And so the first muscle you see really here at the top is deltoid, and then you get deep to it, and then you can start to see these bony landmarks. So Alan's going to explain this better than I can.
Next we're going to move to the posterior shoulder, and the first thing I capture is actually the humeral shaft in the short axis. So this is the humeral shaft right here. And what I'm going to do is I'm going to move the probe superiorly, also with the anterior point laterally, and what you'll see is that when you go to the humeral head, it becomes all knobbly. Once it becomes knobbly and large, you actually start going more medially, and once you go more medially, you actually capture the infraspinatus tendon insertion onto the greater tuberosity right here. And in order to demonstrate that, I'm going to have the patient actually externally rotate And you can see that infraspinae is actually contracting and then have the patient go back into neutral. And you can see that infraspinae is moving right there. Deep to the infraspinae, you actually have the humeral head and the glonon right here. And right here, this hyperechoic structure, which sometimes appears triangular, is the actual posterior labrum.
Okay, well that wraps up all we're going to do with the shoulder. We're going to move now into the knee, and the quadriceps tendon is actually quite easy to see. You just sort of plop the probe down here on the anterior knee with the indicator superiorly, and we can see down here the quadricep muscle eventually turns into the tendon, and the tendon just inserts itself here on the patella. And there's this prefemoral fat that we can see on top of the femur here quite often. And here's Alan explaining it.
So here I'm imaging the long axis or longitudinal view of the quadriceps tendon as it inserts onto your superior patella right here. This is the femur right here, and you can appreciate a stripe of anechoic fluid, which is the prepatellar fat right here. And when I actually have the patient flex her knee, you can see that that actually extends out the quadriceps tendon.
So to be clear, this is the femur down here. He initially said this was the femur here. That's actually the tibia. Slight error I just noticed. So in the beginning of this video, and I'm sorry, and I just made a mistake too. This is not the tibia. This is actually what? The patella. Okay, so femur, patella, and this is that quadriceps tendon coming across here. It's easy to get mixed up. You can imagine how many takes we had when we did this originally. But I'm going to keep rolling. Now we're in the transverse plane. Transverse, it gets a little bit harder to see. This is the femur here, seen as transverse plane, and this is that quadriceps tendon seen here. And what we're doing is we're taking the probe and we're going more superiorly and then more distally, and that's basically what's happening in this video. So we eventually get into where the muscle is and it stops being tendon. And then we come back down to where the tendon is. The tendon's got that fibrillar pattern to it. When it's in the short axis, it looks sort of punctate. The still image represents it here. And remember, there's always that prefemoral fat pad just above the femur there. Now Alan's going to show you how to do this in the short axis.
So you can see that in the short axis, the quadriceps muscles will actually turn into the quadriceps tendon right here, and you can just follow that as it goes into the superior patella right here. Let me see right there. And this is the patella right here.
Pretty easy to see. Okay, now what I did next was I wanted to see the attachment from the patellar all the way down to the tibia down here. And so I couldn't get it all on one view. So I got like this part of the tendon, and then I got this part of the tendon as it went onto the tibia. And I basically stitched the images together here using the mask feature in Keynote. Really easy to do and kind of cool looking how it comes across like that. The patellar tendon seen there. And here's Alan describing how to do that a little bit better.
So next we're going to take a long axis view of the patellar tendon. It inserts on the inferior patella, and you can trace it with its fibular pattern all the way down until it actually inserts onto your tibial tuberosity right here. This is the tibia and the tibial tuberosity right here.
Perfect. Okay. Now let's take the probe from that sort of anterior approach, and now let's move it medially to get a coronal approach. When we come from the side of the body, it's coronal. And so we're going to move it into the coronal view from the medial aspect of the knee. And what we can see quite easily here on this cone down view is the femur, the tibia, and in between the femur and the tibia is this medial meniscus. Quite easy to see on ultrasound. And even easier to see, I think, is this medial collateral ligament as it's coming across. In fact, we can see both the superficial and, as my arrow is pointing along, the superficial and the deep aspect of the MCL. The deep aspect is right here, and there's a little bit of anechoic material in between that two areas there, a little bit of a maybe some fibrofatty tissue, what some people call a little bit of maybe it's a bursa that's in between here, but it's a very characteristic pattern. Let me have Alan show you how he did it here.
So now I'm imaging the medial knee, and what I see is the superficial and deep fibers of the medial collateral ligament, and just deep to that is the medial meniscus. And here is the femur, and here's the tibia right here.
Awesome. Okay. Now we're going on to the wrist, and then this lecture is over. So just hang with me here for another few minutes. This is a transverse view here, short axis of the wrist. We can see the flexor carpi radialis, and the median nerve, and the palmaris longus. Now, I would never expect really me or anybody to pick those out based on a still image, and that's really where I need to make a very critical point here with all of musculoskeletal ultrasound, is that you're moving the probe a lot in order to view structures. And so what we did was we moved the probe up and down Stacy's arm probably 20 or 30 times before we concluded that this was the flexor carpi radialis, and that was the median nerve, and that was the palmaris longus. And so here's Alan doing...
This is the median nerve right here. It's got a honeycomb structure or vesicular structure. To the ulnar side, you actually have the palmaris longus, and then to the radial side, you have the flexi carpi radialis. And to confirm that, what I'm going to do is I'm just going to trace more proximally, and you can see that the FCR and the palmaris longus and the FCR actually go into muscle, whereas the median nerve continues on in its vesicular pattern.
Yeah, so it really took moving up and down the arm to confirm that that was those structures. You can even see the distal radius here, maybe a little bit of the ulna. This is the radial artery seen over here. So we do that a lot clinically too, like when I'm about to do a procedure where maybe I'm going to do a regional nerve block up the median nerve, radial nerve, what have you. I go up and down the arm several times, confirming I'm looking at that structure before it turns into my target. Now, let's move into the wrist here a little bit more. We're going to see in a longitudinal view, again, this is proximal, this is distal, indicators proximally, and we can see in a longitudinal axis, we can see the radius as it comes along here, and then we can see the lunate, and then we can see the capitate. And so these are the little joint spaces in the wrist, and the flexor carpi radialis is coming along here superiorly. Again, this took a lot of moving the probe around to confirm I was looking at those structures. And if I come a little bit more towards the thenar eminence, what I can see then is the scaphoid bone here. And we can see that flexor carpi radialis is coming along, and this is the scaphoid. I hit the little zoom function on the sonocyte, and the scaphoid blew up, and it's nice to see that bony cortex there of the scaphoid. So you can pick out these bones in the wrist. Actually, it's not that difficult once you get your bearings, and then you can move on into the hand and check out the pulley system of the hand. Here we have the third metacarpal coming along, and then it terminates, and then we can see the proximal phalanx right here, and this is the joint space right here, and we can see the tendon coming across quite well. In fact, if you flex the fingers, you can see this tendon moving back and forth. Now, we didn't use a water bath here. We used lots of extra gel, as you can see. Ideally, though, you would put the hand in a bucket of water. The probes are all waterproof. That's fine. You could put the probe in there, and you can actually see this probably a little bit better. And if I move more distally down the finger, I can see here, this is, it looks like it's the short axis of the proximal phalanx, but actually the probe lost contact with the skin here, and actually we're just not seeing the signal very well. But the finger sort of terminates here in its long axis. The proximal phalanx does, I should say. And then we've got this PIP joint, and then here's that middle phalanx, and then the DIP joint is here, and here's that distal phalanx seen over here, and the tendon's marching its way along. Now, this little area right here looks like there could be a tendon disruption, but it's not. This is just that, remember that concept when the probe gets slightly off axis to the tendon, sometimes you'll see that anisotropy, and that's all that is right there, some anisotropy, maybe a little bit more anisotropy going on right there. So it's just wanted to kind of point that out. Well, that basically concludes everything that we're going to try to get through today. I mean, I didn't cover anything with the hip or the ankle or the elbow, or the, really didn't get into the foot or many other structures that we can see in the musculoskeletal system. We focused on the shoulder and the knee and the wrist, a little bit of the hand, just to kind of give you an overview of what these different tissue types look like and some of the functionality. And keep in mind, it's what a lot of people refer to musculoskeletal ultrasound as, I hear this quote over and over again, is MSK is the wild, wild west of ultrasound. And so a lot of future work that could be done here, but certainly it's something to be familiar with, and I think it really helps to round out your understanding of anatomy and some of the functionality of the MSK system. And you can imagine how many takes we have. We just have a couple little bloopers here. Alan is, he's pretty serious guy, I would say, and it's funny to see it when he messes up and stuff.
So this is a long axis view of the patellar tendon inserting. Actually, take it back. This is the quadriceps, but it's the same tendon. So.
It's the same tendon. And then Alan drops an F-bomb.
So this is a long axis view of the patellar tendon. You can see that it inserts. Fuck! I did it again. Okay, sorry guys.
See, now I have to make this podcast explicit. All right, thank you very much, and have fun in your scanning sessions.